Good morning and welcome to UCLA Health. My name is Isaac Yang and I'm a neurosurgeon here at UCLA. My specialty is brain tumors and brain cancer and skull-based surgery, and we're going to be talking to you today about treatments for intracranial brain metastases. I'd like to thank UCLA Health and the UCLA Health System for allowing me to give you this opportunity to stream this over the internet so that you can all come to UCLA without having to physically come here. If you have questions, we're available at UCLA Health on Twitter. Also, use the hashtag UCLAMDChat if you have any thoughts or comments, and that you could send them in. We have a whole team here reading your comments. We're going to be talking today about treatments for intracranial brain cancer. Now, brain cancer, when you hear the word brain cancer, that's probably two of the scariest words that you can put together in one sentence. But when we talk about brain cancer, there are two kinds of brain cancer, really. There's brain cancer of the brain the brain cells that grow into brain cancer, and then there's brain cancer that comes from other parts of the body, lung cancer, skin cancer, breast cancer, and it spreads to the brain and starts growing in the brain. So there are two kinds really of brain cancer, and they're just as common. There are just as many cancers that go to the brain from the breast, the skin, the lung, and other sources as there are brain cancers that grow primarily from the brain. And what is cancer? Cancer simply are cells that just keep growing. You find a normal cell, any kind of cell in any part of your body, and it keeps growing and multiplying, and if it doesn't stop, that's cancer. And if it comes from a skin cell, we call that skin cancer. If it comes from a brain cell, we call it brain cancer. If we call it a lung cell, then it's a lung cancer. And today we're going to be talking about brain cancer that comes from other parts of the body. Breast, lung, kidney, skin, the stomach system. Cancers that invade the brain from other parts and that keep growing. And this is a problem because the brain is very, very important. And cancer, the reason why cancer is such a scary word is that cancer is talking about malignancy. And malignancy really is referring to the speed at which it grows and invades other parts of the body. So if it's growing fast, we call this cancer. So it grows fast and grows into other parts of the body, and when it grows into other parts of the body, we call that metastases. And the reason why brain metastases are such an important part is that the brain is a limited space. You only have so much brain. And so when it starts invading the brain, it starts causing big problems. And the question is how to treat this. And so today we're going to talk about how do you treat brain cancer when it's come from other parts, when there's only one cancer that's spread to the brain. What happens if the invasion has spread into multiple little seeds and has seeded several parts of the brain? How do we treat that? We're going to be talking about treatment algorithms. We're also going to be talking about cutting-edge laser surgery that we do here at UCLA, that I do and Dr. Paradian does, and that this laser surgery is really cutting-edge ways to treat brain cancer that's spread from other parts after it's failed radiation. And again, if you're interested, you can follow us at UCLA Health. It's a fantastic Twitter site run by Ashley here at UCLA, as well as tagging us with hashtag UCLAMDChat. Now, the background for this, how common is this? Well, if you look at all the people who have all kinds of cancer, any kind, breast cancer, lung cancer, any kind of cancer, about a third of them will have brain cancer. A third of them will have cancer from those spots that have spread to the brain. So that's quite a big number. When you think about all the people with cancer, think about a third of them have some invasion of either the brain or the spinal cord. That's a huge number. But the real reason why this is such a pressing issue is that we believe that the incidence, that number of frequency, that how often this is happening is going up. More people are getting brain cancer from other kinds of cancer. And the reason why this is happening is because we're getting better at treating breast cancer and lung cancer and skin cancer. All the other cancers, we're getting really good at treating them. And as we get better at treating people with breast cancer and lung cancer and skin cancer, and those patients are living longer and longer and longer, it gives their cancer a higher chance to invade the brain. In the past, when you got breast cancer, lung cancer, skin cancer, you died so quickly, you didn't give that cancer a chance to spread to the brain. But now, with cutting-edge, multidisciplinary, complex, personalized focused therapy, our patients with breast cancer, lung cancer, skin cancer, all different kinds of cancer, they're now living longer than they've ever lived before. They're living longer with better quality of lives than ever before. And because they're living longer, now the cancer in the other parts of the body, they have more time, more chances to escape and invade the brain. And this is why this is becoming more important. And cancer to the brain, like we talked about, makes a big impact to the quality of life. Because even though it's only this big in the liver, it won't make a big difference. But if it's this big in the brain, you may not be able to move or walk. And so it makes a big difference when it invades the brain. And it can cause headaches, seizures, problems with moving, problems with talking. And the best way to identify this in patients who have systemic cancer, other kinds of cancer, is to evaluate their brain with a brain MRI with and without contrast. That's really the gold standard to detect brain cancer from other parts of the body, is a brain MRI with and without contrast. And so this is just as frequent as cancers that start in the brain. Brain cancer that comes from other parts of the body happens just as frequently as cancer in other parts, as the cancer that starts in the brain. And in the United States, there are almost 200,000 cases of cancer that spreads into the brain from other parts every year. And every year, about 100,000 patients die each year from brain metastases. This is a very serious and a huge problem that we deal with. And the most common sources of brain cancer that comes from other parts are these right here. The most common source is lung cancer. The second is breast cancer, melanoma skin cancer, GI cancers like colon cancer, and other primary cancers like kidney cancers and other more rare tumors. But the most common kinds are lung, breast, skin, and colon cancer. And I know we just finished Breast Cancer Awareness Month. And so for all those patients with breast cancer, a good quarter, 25 to 30% of them at some point may have intracranial metastases. So they will become brain cancer patients that are fighting that breast cancer in the brain. And how do we deal with this? And if there's no treatment, survival is extremely poor. That once the cancer has metastasized and starts invading the brain, unless you do something, you're looking at a poor survival. And so once you see brain cancer from either lung, breast, skin, or colon cancer, it's time to do something. You have to do something. Observation is not really an option. Well, what do you do? What do you do? Well, back in the day, the only option they had was surgery. You have cancer that's come to the brain, we're going to open your skull and take it out. Well, now what we're trying to do is make it as minimally invasive as possible. How about non-invasive, like radiosurgery? Minimally invasive through laser surgery. And we're trying to give it the most beneficial outcome with the best quality of life, individualized, personalized for every patient. So what we're doing is, as patients go see their oncologist, they're going to do screening MRIs. Like we said, the gold standard is a brain MRI with and without contrast. And so this is an example of a patient who has a brain MRI, and they have this small lesion. You see this right here. You see this very small one lesion. It's less than 1 centimeter, and it's small. And this person has a breast cancer or a lung cancer, and they had this small sub-centimeter lesion, and it's causing them no problems. They had no symptoms. They found this because their doctor was a good doctor, a good oncologist who said, we're going to do a screening brain MRI with and without contrast, and we found this. Now that we found this, what do? You have no symptoms of any kind, and you have a sub-centimeter lesion, and we know it's likely to be cancer from somewhere else. What's the best treatment algorithm? Should we just open your skull and take it out? And I don't think that that's the right answer. For that lesion there, I wouldn't recommend open surgery. I would not recommend neurosurgery. Yes, I am a neurosurgeon. Yes, I do brain surgery. And for that lesion, I would not recommend brain surgery. I would actually recommend radiation or radiosurgery first. And then if that fails, I'd recommend laser surgery. And that's just customized, personalized, individual treatment because every single patient is different based on the primary cancer, how bad is a systemic disease, and how much intracranial invasion is there. And so I really think that the key to optimal brain cancer therapy is individualized care. A patient with lung cancer is very different from a patient with breast cancer, who's very different from a patient with melanoma or skin cancer. And that each person has a unique fingerprint. Each person needs a customized therapy from oncologists that work together with neurosurgeons, that work together with radiation oncologists, that work with nutritionists, dietitians, physical therapists, a multidisciplinary team to create a custom game plan. This is very important because I think each patient is different. Each person has different kinds of symptoms. And so this approach together will create a balanced treatment. This balanced treatment is so important because we want to control toxicity, side effects, and quality of life. You want to live the longest life possible with the highest quality of life possible. And that balance is so important. That balance is so delicate. And that's the importance of developing that relationship with your doctors and with your surgeons. So what are our options today? Today we have chemotherapy, we have whole brain radiation, we have stereotactic radiosurgery, or focused beams of radiation, which we're going to talk about, and open neurosurgery, which is where we do a craniotomy and take it out. And what I'm going to end today with is cutting-edge laser neurosurgery, which is minimally invasive neurosurgery, but treating the lesions with a laser instead of open surgery. And we'll talk about that at the end of today. Well, where do we get this evidence? It comes mostly from the literature, from the science that we have, over the experience that all the doctors have had for the past 50 to 60 years. We put this together to try to create the best game plan for our patients. So if you have one cancer that's spread to the brain, if it's in a surgical area, what's the best treatment? And in this study, this is a landmark study by Dr. Patchell in the New England Journal of Medicine. It was published in 1990. And they looked here at resection versus biopsy. And both of these patients groups got radiation. So they looked at whether you took the cancer out that was in the brain versus a biopsy. And they looked at overall survival. And here the overall survival was roughly 40 weeks. And in this category, it was about 15 weeks. And that this was a huge difference, not just in terms of weeks, but when the statisticians did the numbers, this wasn't just by chance or a fluke. This was a real difference. And so if you have one lesion in the brain that's from another cancer somewhere else, a breast cancer, a lung cancer, or skin cancer, that's gone to the brain from somewhere else, and you only have one, and it's surgically accessible, the best recommendation for living the longest would be to take it out. And that's really for the most symptomatic and large lesions. But what about that lesion we saw before, that small sub-centimeter lesion? I don't know if I would recommend surgery for that because it's so small and asymptomatic. My first recommendation would be radiation. If the radiation fails and then continues to grow, then yes, my recommendation would be to do this, which is surgery, and take it out, because those patients will live longer. We then looked at, well, does the radiation make any difference? And they looked at patients who got resection, surgery, versus resection and radiation. And this is by the same group. This was in the Journal of Medical JAMA, and this was published in 1998. And they found that there was a big difference in local recurrence versus just getting surgery versus getting surgery and radiation. That surgery plus radiation was the best outcome. And so if you're going to get surgery, you should also strongly consider getting radiation. That this combination was the way to work. Now at UCLA, we don't just do surgery and surgery plus whole brain radiation. We now do surgery plus stereotactic radiosurgery. We try to focus the radiation because we don't want the cognitive side effects. And I'll show you how we put those two together, that we create this custom game plan for our patients. So if you have a solitary lesion and it's creating mass effect and symptoms, I believe surgery is the best option. Why? It removes the mass effect. It takes the pressure off the brain. If it's big enough to cause pressure, that's not good. You need to remove it. Number two, you need to confirm diagnosis. Every surgeon, neurosurgeon that focuses on brain tumors and brain cancers, we've seen this. In about 10% of cases, it's not the other cancer that's come from breast, lung, or skin. It's actually the other kind of cancer, brain cancer that started in the brain. And knowing which kind of cancer is actually very important. Why? Because then we can customize our chemotherapy. We can customize our radiation and chemotherapy to target that tumor. Instead of firing missiles that are going after the wrong target, if we know it's brain cancer that's coming from the brain versus brain cancer that's coming from the lung or the breast or skin, we have different chemotherapies for each kind. And that's really important because that lets us customize and aim our chemotherapy like a heat-seeking missile for these different cancers. But overall, the reason why surgery is the best chance is because, like that study showed, doing a biopsy creates a certain survival. But if you take the whole thing out, you improve your chances for longer overall survival. And so ultimately, if you have a lesion that can be operated on and removed entirely, surgery has to be the best option for this. And if you combine this with radiation, you get the best effect, combining surgery with radiation and chemotherapy from your oncologist. Those three have to come hand in hand. And by the time that any of these cancers have invaded the brain, whether it's breast cancer, lung cancer, skin cancer, once they've invaded the brain, it's time to act. You have to do something. Observation is not an option. Well, not every patient can get surgery. What are reasons not to? Maybe they're too sick. Maybe the cancer is in too many parts of their body, their heart, their liver, their kidney. It's not functioning well. And maybe the surgery is too high risk for them. If they're elderly, we know that the older you get, surgery gets harder and harder on your body. We know this intuitively. And so if you're older and you have this issue, surgery may not be the option. If you're not functioning well, or if you have leptomeningeal disease, which just means that the cancer has spread too far, surgery is not a good option. And in some of these patients, the laser neurosurgery, which I'll show at the end, may be a better option. But for the open neurosurgery, these are the contraindications. The biggest predictor to how long people are going to survive after taking out one cancer lesion in the brain is the burden of systemic disease. So if you have breast cancer and it's spread all over your body and you have one lesion in the brain and we take it out, that survival may be longer, but it's not going to be so good. But if you have breast cancer and your oncologist and your chemotherapy have it under control, it's not in the other parts of the body, it's all clean, and you have one lesion in the brain and we take it out, that patient's going to do much, much better. So the biggest prognosis is the systemic disease, and that makes sense. It's the cancer that comes from other parts of the body. You can't just win one portion of the battle. You have to keep your eye on the entire war. You can't just win one portion. You want to win the whole thing. And so because of this, you need multiple doctors. You need a whole army fighting for you. An oncologist, a radiation oncologist, a neurosurgeon, dietitians, physical therapists, a support network. You need this whole army to go to battle with you. And we need to fight on all fronts, both on the brain cancer front, the brain surgery, chemotherapy, radiation, and on the systemic front, which is the cancer in the other parts of the body. Well, the next portion of my talk is going to be about radiation. And radiation has quite a stigma. Back in the day, we feared radiation waves. There's the Fukushima nuclear power plant destruction. There's the atomic bomb. There's quite a stigma to radiation. But radiosurgery and radiation may actually be surgery and medicine of the future. Radiosurgery is where we do targeted, pinpoint beams without opening your skull. It's where we can reach into the body with a little probe and do treatment without ever affecting your body. Radiation has no scar, no injections, no pain. It is a non-invasive way for us to treat different kinds of tumors and cancers. And there's different kinds. There's conventional whole brain radiation, which is the gold standard and the oldest way. And there are now newer, more precise and focused ways, which is SRT, which is stereotactic radiotherapy, and SRS, which is stereotactic radiosurgery. And those two are really just the same, except it just differentiates how high the dose is and how many times you have to come get the radiosurgery. And if you get it a lot of times, they call it radiotherapy. And if you get it a few times, they call it radiosurgery. And there are different brand names: Gamma Knife, Linear Accelerator, otherwise known as LINAC, Synergy, BrainLab, CyberKnife, all these different brand names, but they're all essentially the same thing. They're all essentially radiation, focused radiation, stereotactic radiation, whether you call it radiosurgery or radiotherapy, different brand names to the same kind of radiation. And so for whole brain radiation, there's a good thought, and this is the oldest kind, which is you just want to treat the whole brain. We know that cancer is spread to the brain from the breast, the lung, or the skin, and they're asking, well, where else can it go? Well, once it started invading the brain, you know that Pandora's box is open. It can go to any portion of the brain. And so the rationale here is, well, if it can go anywhere, let's just zap the whole brain with radiation. Let's zap everything we can with radiation. Well, we do know two things. Number one, this study came out in 1954. We've known for over 50 years that if you get radiation, we know that these patients, they live 2 to 4 times longer, that radiation helps patients live longer. This is a gold standard treatment. People with brain cancer should get radiation. And so this was a retrospective study looking at this. This was more current. This was done in 2010. And people who got whole brain radiation had decreased distant recurrence, and they had better overall survival after surgical resection. But there's a downside to whole brain radiation. And this makes sense. If you radiate the entire brain, they get problems with the way they think. Now, this doesn't happen to every patient, but it does happen to enough patients where most of the academic centers, we try to avoid radiating the whole brain if possible. We still do it, but we leave it as an option of last resort. If we can do focused radiation first, this is preferential to doing whole brain radiation. And the reason why is this paper came out in 1989 from the MD Anderson group, which is that radiation, whole brain radiation, caused dementia and caused thinking problems in patients who were treated with brain cancer from other parts of the body. And so if you can avoid whole brain radiation, we try to avoid it first. There are other problems with whole brain radiation. There's significant hair loss, skin toxicity, fatigue, and so we want to try to avoid whole brain radiation and change that out with radiosurgery, which is focused radiation just on the area of the cancer, because radiosurgery and focused radiation have less side effects. Well, what if you have multiple brain cancer? If you have cancer that has spread to multiple parts of the brain, we can't do surgery. It's too focused. We can't do stereotactic radiosurgery when you have too many. When you have more than 9, 10, 12, 30 lesions in the brain, that focused radiation is not going to work. And so in those areas, we need to do whole brain radiation. We need to do radiation to multiple areas. Well, what about if you just have a few lesions? What if you only have 2 or 3 lesions in the brain? What are you supposed to do then? And this is a courtesy of my colleague, Dr. Ganesh Rao from MD Anderson. They looked at studies where people had 2 or 3 lesions. What do we do then? And they found that if you have 3 or less lesions and you do surgery to completely remove all 3 lesions, they're also going to have good outcomes. That removing 3 lesions was just as good as removing 1 lesion, as long as you can remove it all. So if you have 3 lesions and we can remove all 3 lesions in one surgery, surgery may be strongly considered. And after the surgery, I would even say you need to get radiation, whether it's whole brain radiation or focused radiotherapy to the resection cavities. That would probably lead to the best outcomes. So in practice, how do we do this? In patients with multiple lesions to the brain, we only try to focus on the ones that are symptomatic, the ones that are causing problems. The other ones we're going to try to treat in the most minimally invasive, least impactful way, because we want to maximize quality of life and improve survival. We do treat with whole brain radiation when there are too many lesions and when all the other options have failed. Radiosurgery is focused radiation to a specific area. And this is a very fantastic way to treat lesions, because here what you see is this is 2 different ways to do radiosurgery, whether you go through radiation through all these different beams or the machine moves around you. We use bunches of different kinds of targeting to focus the radiation on one spot. And that's why it's called stereotactic, and that's why it's radiosurgery focused on that spot. There are ways that this can cause a lot of harming, though. And I think in this regards, for radiosurgery and radiotherapy, experience matters. You want to go to a high-volume radiosurgery, radiotherapy place. This is from the New York Times, published in 2010, showing how when radiosurgery has complications, it can cause a lot of problems. It can harm instead of heal. But if you do this in the correct and safe manner, it can make a big difference. This is actually one of my patients here. You can see that one solitary lesion in the left frontal lobe. One cancer, this is lung cancer actually, that spread to the brain. One lesion, asymptomatic, less than 1 centimeter. What do you do? Well, if you went straight by the textbook, it would say, look, you have one solitary lesion, do brain surgery, take it out, they live longer. And that's the textbook answer. But we're moving beyond the textbook. Is what can we do to make our patients' lives better and still treat the lesion, help them live longer? Well, for this patient here at UCLA, we did radiosurgery. We did focused radiosurgery to that lesion, and this is that lesion post-radiosurgery. is that that lesion has now disappeared. And so without surgery, without opening your skull, no injections, no scar, no knife, no pain, we made this brain cancer disappear. And now I wouldn't ever go and use the word cure. We did not cure cancer. There's no cure for cancer. What we're trying to do is stop or slow it down. And so what we did for this cancer here in the brain is that we put it down. We made it essentially shrink so much that you can't see it in that location. And that's what we try to do with the radiosurgery, is that we try to kill those cancer cells that have spread to the brain. And this patient still needs careful observation, still needs an oncologist to treat the systemic disease, needs a radiation oncologist and a surgeon to follow them carefully for this brain component of their disease. And this is well published. This is multiple studies reporting LINAC, Gamma Knife, in series of up to 200, 400 patients, 100 patients, large series of patients that have been treated. So it's not just us here at UCLA. This is a very good standard of care, treating with radiosurgery, and that they have excellent local control rates, and that this is an effective way to treat. And this is published in 2004 from the Radiation Brain Tumor Group, where they think that standard treatment for patients with a single, either unresectable or asymptomatic lesion when they're small, when you have 2 or 3 brain cancer lesions, the first option should be radiosurgery. It's safe, it's outpatient. You don't get to the hospital. You come and get radiosurgery, you go home and have dinner with your family. It's really revolutionized the treatment of brain cancer from other parts of the body. There are some downsides. It's only treating a focused area, and so it doesn't treat the rest of the brain. And so there's a slightly higher chance that the cancer may come up at other parts of the brain. This is why surveillance is so important. We have to watch you with MRIs every 4 to 6 weeks. Why? If it comes up in other parts of the brain and it's small, we can treat those with radiosurgery as well. As long as it's small, without much mass effect, we can keep treating with radiosurgery. But if there's multiple lesions, too many, or they're too big, radiosurgery will no longer be an option. Sometimes radiosurgery, because it's focused and high-powered radiation, it can cause swelling. And I'll show you an image of this. And this is one of these complications of radiosurgery. You had a small lesion here that was treated with radiosurgery, and this white around it is a swelling. After the radiosurgery, this white here is the increased swelling. And so when in these instances where we have increased swelling, we will need to treat with Decadron or steroids to help reduce the swelling. And if the steroids don't improve the swelling, ultimately that patient's going to need to have open neurosurgery. I still think radiation is a good option for small asymptomatic lesions without much swelling, because if they end up with surgery, they would have had surgery anyways. And so I think radiation has to be considered at least either a pit stop to surgery or considered as a very strong option for a first choice. What we're doing here at UCLA is actually trying to get the best of both worlds. So what we do is when we see a single solitary lesion or a lesion that gets surgery with multiple lesions, and there's one lesion that's really big, we'll do surgery, neurosurgery, and take out the biggest offending lesion completely. We'll completely take it out, or we'll do the best and safest surgery to take out as much as we safely can. And once we've taken out as much as we can, or the entire thing, we're going to do a combination, a hybrid of surgery and radiation. Once we do the surgery, after the surgery, we do focused radiation to the resection cavity. Once the cancer is removed, what you have is like a cup that used to hold the cancer, and the cancer was removed. Well, what we do is focused radiation to the edges of the cup. We're trying to combine the best effects from both surgery and radiation and putting them together. And so we do a radiosurgical boost to the surgical bed, so that that area that has the highest risk of recurrence is also treated with radiation. And so this is the combination. This is trying to put the best of all worlds together, both the radiation and the surgery, so we can treat our patients with a customized approach. This is a case. This is an actual case of a patient with lung cancer. This is courtesy of Dr. Kim. He was my research fellow last year here at UCLA. We had a 73-year-old woman. She had lung cancer. And this lung cancer went to the brain. And here you can see it's of quite a large lesion. It's in an area that's not the best for surgery. And because of its large size, it's not good for radiation. So what's a good option here? We're pushing the cutting edge. And the cutting edge here, the textbook answer would be, well, then do surgery. If you can't do radiation, do open surgery and take it out. Well, we're trying to create a customized, individualized, maybe kind of at the edge of the textbook, kind of marching to the best path to do the most minimally invasive, least invasive, highest quality of life. She's 73. She did not want to have open, crazy surgery. And so what we did was we used a minimally invasive catheter to drain the cyst. You can see that after we drained the cyst through a very, very small hole, the cancer got smaller because we drained off the fluid. And then once we drained the fluid and we made the cancer smaller, after that we treated with focused radiosurgery. And after we treated with radiosurgery, this patient, she had a remarkable response. You can still see parts of the cancer here and here, but it's got much, much smaller. And so this was not textbook. This was cutting edge. This is us trying to find the best path. It's a journey. She didn't want to have a big, open, painful surgery, but she was willing to have a smaller surgery, a smaller tube to drain the fluid, and we just took it as a path along in which we said, if it's safe and there's a good chance it'll work, let's do it. And so we did this together, and so we are now researching ways in where people who have cystic lung cancers, this is with Dr. Percy Lee in radiation oncology, as well as myself, we're looking at lung cancer that goes to the brain, and if there's a cystic component, can we drain the cyst through a minimally invasive surgery and then treat the residual with radiosurgery and get good outcomes with minimally invasive approaches. In conclusion, I think the take-home points are, if you have a single solitary MET, you should probably be as aggressive as possible. If it's small, less than 2 centimeters, with no symptoms and little swelling, radiation, radiosurgery is the best option path. If it's a solitary MET that's too big or causing symptoms and is surgically accessible, surgical resection may be the best course of path. If you have too many lesions, more than 3, more than 10, more than 15, then usually you'll need palliative therapies, such as whole brain radiotherapy. We use whole brain radiation, but only as an option of last resorts. And if you're somewhere in the middle, oligomets, you have 2 to 3 to 9 lesions, this is really where you need to have a whole team come together. And we discuss our patients at both our radiosurgery tumor board and our UCLA tumor board. You need a personalized, customized, individualized treatment plan that maximizes your quality of life, maximizes your overall survival in the least painful, least invasive, and non-invasive option as possible. So I told you I was going to talk about laser neurosurgery. Well, this is what we do now. This is a patient who had a cancer that went to the brain. This came from another portion of the brain, and this one's actually breast cancer. This patient had breast cancer, and it spread to their brain. And you can see this white area here is where the cancer had spread to the brain. This patient had previous surgery, and for this one, because it was small and asymptomatic, we did that. We treated with radiosurgery. And for 1.5 years, the cancer did not grow. So for 1.5 years, we got outstanding results. The radiation was going well. And then after 1.5 years, the cancer started growing again. So this was a breast cancer that went to the brain. It was small. It was treated with radiation as a first option. And then after the radiation, it started growing again. At this point, the traditional approach would be to do open neurosurgery. We open her skull, we go in and take it out. Because it's already been radiated, we can't radiate it effectively again. And so because it's been radiated and now it's growing, the textbook answer would have been open her skull and take this out. Well, what we did for this patient, cutting edge, we did laser neurosurgery. We drilled a hole in her skull that was 3 millimeters big. 3 millimeters. That's like the size of a coffee stirrer. A little bit smaller, actually. We drilled a super small hole in her skull. And then we passed this laser into this. And you see that blue line? That's the targeting in which we wanted to pass it. Now, this is us. What we did is, you can see the catheter. It's in the cancer. You see that black line? We drilled the small hole the size of a coffee stirrer. And then in the OR, we passed a laser catheter into the cancer. So we take the patient to the OR, we put her to sleep, we intubated her, we saw the lesion, and using brain lab neuronavigation, it's like GPS for the brain, we drilled a very small hole and we passed. We literally threaded the needle. We literally passed a very small catheter through this very, very tiny hole into the brain cancer. This was the breast cancer that spread to the brain, and we passed this little tiny catheter into it. And then after we do that, we take the patient from the OR, still asleep and intubated, to the MRI suite. And this is the MRI that we get. This is why the MRI showed the laser catheter. It's still in place. And then once it's in place, we activate the laser, and you can see it starting to activate here. This is an action GIF. And you can see that here, this orange pathway is the area of the cancer that we're destroying with the laser. So once the laser is in place, you see that test dose. This is when we're activating the laser. Now the laser is actually starting to do its job, and we can see the portion of the cancer that we're killing. The reason why this is revolutionary is because we're doing this in real time. In the past, when people used lasers or other ablative methods to the brain cancer, the portion that was dangerous was safety. Could you watch this happening in real time? The reason why this is safer is because we're in the MRI suite. We're watching the temperature and the laser and the effects of the laser in real time, so that if the damage goes beyond this area, we shut the laser down immediately. And so this is a really effective way to treat cancer that's spread. And so this was the lesion. You can see the black line, which is the catheter. We put the laser catheter in, and then we treated and we ablated. We killed the cancer that was treated with radiation, and then it's kept growing, and so then we killed it with a laser. And after the MRI, we pull the patient out of the MRI suite, we pull out the laser catheter, we put in 2 staples, we extubate, we wake her up, and then she goes home the next day. It's really remarkable and revolutionary surgery. It's very cutting edge, and we're doing that here at UCLA. And I think this is really the future, is we're going to get surgeries that are smaller and less invasive, and we're going to get more individualized therapy. That as we get molecular and genetic profiling of people's individual cancers, we're going to get better at throwing specific heat-seeking missiles for those cancers, for those therapies, specifically aimed at that. And we're going to be starting to do a smaller and minimally invasive surgery like this laser surgery instead of big open surgeries. I think this is the journey that you want to be on. This is the UCLA Journey for cancer. It's not a destination. It's a journey that you and your doctor and your multidisciplinary doctor, doctors who do specific things really, really well, who are focused on just that one thing, you put them together as a team so that they come up with a personalized, individualized, custom treatment based on your cancer's fingerprint, based on your cancer's growth, based on your cancer's body spread, and based on your cancer's spread into the brain. This can only be done if you have a close collaboration, really friendship between your oncologist, and we have fantastic oncologists here at UCLA, including Dr. Glaspie, Dr. Guerin, radiation oncologists with Dr. Percy Lee, Dr. Tanya Kapralian, Dr. Phil Barron, Pat Kupalian, Michael Steinberg. We have fantastic radiation doctors here. Neurosurgeons, a whole neurosurgery brain tumor team, Dr. Neil Martin, Dr. Linda Liao, Marvin Bergsnyder, Nader Paradian, and myself. Palliative care experts, social workers, nutritionists, pain specialists, they all come together to fight cancer in a multidisciplinary team. There's more than just cancer, though. We have a UCLA East-West medicine program. I get asked that a lot about holistic treatments, about other ways to treat this, that cancer isn't just a disease, it's about getting people in the right state of mind. All pun intended, brain surgery and getting people in this right state of mind for their brain, that we look at people as an individual, as a whole person. It's not just breast cancer or lung cancer. How do we get this to work together? And once we have the specific molecular profile and the genetic profile of the cancer, that the very best doctors and the very best experts, they sit down every week together, if not every day, to work out a specific plan for people. And that everyone here at UCLA is on this journey. I'm so honored and so privileged and so proud to work at UCLA, where all these cancer doctors wake up every day and come together to fight cancer, to fight suffering. That sometimes, and the hard truth to admit is that we can't cure cancer. And sometimes we can't cure every patient. But can we care? Can we be there? Can we be part of the team to be a part of your family? Can we go on this journey with you? You betcha. And we do. We will. and we do every day. And I think this is really important, that not only do we bring state-of-the-art, high-technology medicine, but that we bring it together with compassion and caring at one of the best hospitals in the country. Success is a team sport. I would not be here by myself. I need to thank specifically Dr. Rao from MD Anderson and Dr. Michael Lim from Johns Hopkins for being my colleagues in this fight and for helping me put this talk together. I'd like to thank specifically Moyne Kim. He's my research fellow from South Korea who also helped me put this together. And Dr. Andrew Parsa from Northwestern. He's the chair at Northwestern. He also helped me put this together. I want to thank everyone who's a part of my lab, including Kim Thill, Brittany Voth, Nolan Ung, Lawrence Chung. These are the people who helped me do my research, who helped put this talk together and help me with my program. I want to thank everyone here at the UCLA Brain Tumor Program, especially the Neuro-Oncology Group with Dr. Clausey and his team, the Radiation Oncology Group with Dr. Steinberg, Dr. Kupalian, Dr. Kapralian, and Dr. Lee and their team, and also Anastasia Anderson, who's a PA here in the Neurosurgery Department, and the oncologists, especially Dr. Garan, Dr. Glaspie, and the whole team here at UCLA. I need to thank all the funding sources that allow me to do my research, including Stop Cancer and the Broad Stem Cell Research Grant here from UCLA. Without these grants and fundings, I would not be able